Hello and welcome to my YouTube channel. Today we will be discussing a very important topic, and that is a classical surgical triads and some surgical laws. I'm sure this topic would be very useful for all the surgical students. So without wasting further time, let's get started. What exactly is a surgical triad? Let us try to understand first before we go on to discuss individual triads. What is a surgical triad? It's a cluster of three classical signs and symptoms that together points to a specific diagnosis. So we have a cluster of three signs or three symptoms which, if put together, would lead to some sort of surgical diagnosis or specific diagnosis. Now, generally, these triads are named after a surgeon or a physician who described these triads or the symptom complex or the syndrome first. And generally, most of these surgical triads are very favorite in viva questions, even in clinical examinations. So, as a student who is appearing for their exams, I think I would expect that these topic would be very useful for students who would be appearing for such type of exams. Now, coming to what exactly is a surgical law, it's a eponymous rule or a principle that governs surgical anatomy, physiology, or any form of surgical decision making. It distills decades of clinical observation into one memorable statement, which can easily be replicated and easily be recollected. And again, it is basically used in most of the multiple choice questions and clinical reasoning questions, specifically in a lot of surgical examinations. Now, the first triad we would be discussing is one of the commonest ones, and that is a Charcot's triad and Reynolds pentad. Now, what exactly is a Charcot's triad? A Charcot's triad consists of three important symptoms and signs, and that is pain, classically described in a right upper quadrant, which is a colicky pain, and specifically it can sometimes be labeled as biliary colic. The second part or second component of Charcot's triad is a high grade fever with chills and rigors. Now, this type of fever is generally known as Charcot's fever, which is generally an intermittent fever. And the third part of this Charcot's triad is a jaundice, basically an obstructive jaundice, where the patient has passage of dark colored urine, pale stools, and pruritus, all the classical symptoms of obstructive jaundice. So this Charcot's triad basically denotes that there is an obstruction to the outflow of the bile somewhere in the biliary tract, most commonly in the common bile duct. So this triad of pain, fever, and jaundice together goes by the name of Charcot's triad, and classically it describes for ascending cholangitis. And then we have a Reynolds pentad in relation to Charcot's triad, which consists basically of the Charcot's triad plus two additional symptoms, and that is hypotension and mental confusion. So in Reynolds pentad, we have pain, again in the right upper quadrant, mostly colicky pain, fever, which is high grade intermittent colicky fever with chills and rigors, obstructive jaundice features, and on top of that, patient has got hypotension and mental confusion suggestive of sepsis. So such type of patient who has got already ascending cholangitis and who exhibits hypotension as well as mental confusion suggests that this patient is slipping into sepsis and septic shock with encephalitis, and such patients would require emergency surgery. That is the importance of this Reynolds pentad. So emergency decompression or relief of obstruction of external extrahepatic biliary tree should be done as early as possible. Then we have a Virchow's triad, which is basically very essential to understand in the deep vein thrombosis pathogenesis. Three factors predisposing to thrombosis, and this was first described in 1856 by Rudolf Virchow. And what exactly is the Virchow's triad consist of? It consists of stasis, endothelial injury, and hypercoagulability or hypercoagulable state. So stasis or reduced blood flow can occur because of immobility, congestive cardiac failure, venous insufficiency, even in long haul flights of more than 4 to 5 hours. Similarly, we have the second component of Virchow's triad, which is endothelial injury, basically a vessel wall damage, which can occur because of any trauma, catheters, surgery, even smoking and hypertension can lead to endothelial injury and basically increased predisposition to uh, deep vein thrombosis. And then we have a hypercoagulable state or altered coagulation, which can occur in conditions like any form of malignant conditions, pregnancy, patients on prolonged oral contraceptive pills, antiphospholipid syndrome. So these three, the stasis, the endothelial injury, and hypercoagulability, would be a very important factors in the pathogenesis and leading to the development of deep vein thrombosis. Mnemonic you can have SEH, stasis, endothelial injury, and hypercoagulable state. Another triad which is very commonly used in surgical practice is a Cushing's triad, which is generally one of the hallmarks of a raised intracranial pressure. Now, what exactly is a Cushing's triad? It consists of hypertension, bradycardia, and irregular respiration. Hypertension leading to widened pulse pressure, bradycardia because of reflex vagal tone, and irregular respiration, also known as Kane-Stokes respiration, is a classical sign seen in raised intracranial pressure. These three are known as Cushing's triad, and Cushing's reflex is a vasopressor response which occurs and which is a late sign of brain herniation. So this is about the conditions where we have a raised intracranial pressure, which can occur because of any hematoma, intracranial bleed, any intracranial mass lesion or space occupying lesion. All this can lead to a raised intracranial pressure, and patient may exhibit this typical Cushing's triad. Then Cushing's ulcer are different, which are nothing but stress ulcers which occur in a setting of raised intracranial pressure. In a patient who has got raised intracranial pressure, these patients are at risk of development of multiple gastric ulcers, and these are known as Cushing's ulcers. The classical location is in the duodenum and stomach, and the mechanism of development of Cushing's ulcer is basically a vagus nerve overstimulation, which leads to increased gastric acid. And this is opposed to a Curling's ulcer. Curling's ulcers are seen in severe burns. Again, it occurs in duodenum and stomach, but here the erosions are because of ischemia. So the pathology is different here, Cushing's ulcers and Curling's ulcer. Then we have a Beck's triad, which is seen classically in cardiac tamponade. A classic triad in acute cardiac tamponade, first described by Claude Beck in 1935. Basically, it consists of hypotension because of reduced cardiac output from external compression of the heart, increased jugular venous pressure. So we can also have a muffled or distant heart sounds when you auscultate the heart. You cannot hear, or you can hear a very distant or a muffled heart sounds because of sound which is dampened by the surrounding pericardial fluid. And then we have a increased jugular venous pressure, which is basically due to impaired venous return, leading to raised central venous pressure. So classically, hypotension, elevated jugular venous pressure, and muffled or distant heart sounds are seen in a condition which is known as Beck's triad, seen in cardiac tamponade. Generally, such patients require emergency pericardiocentesis, especially in the fourth intercostal space in the left parasternal area. Then we have two of the appendicitis, acute appendicitis triads. The first one, which is commonly used, is a Murphy's triad, and the second one is a Cope's triad. So, what exactly is a Murphy's triad? Murphy's triad consists of sudden severe periumbilical pain, nausea and vomiting, and tenderness over the right iliac fossa. This is a Murphy's triad: pain, vomiting, and tenderness over the appendix. Whereas a Cope's triad consists of a migrating pain from periumbilical to right iliac fossa at the McBurney's point, nausea and vomiting, and low-grade fever plus leukocytosis. These three are known as Cope's triad. So these are the Cope's and the Murphy's triad, which are commonly used in acute appendicitis. Then we have a Horner syndrome and Trotter's triad. What exactly is a Horner syndrome? It's a disruption of sympathetic supply to the eye. And the typical features seen in Horner syndrome are ptosis. That means there's a partial drooping of the upper eyelid, meiosis or constricted pupil, and anhidrosis, loss of sweating on the ipsilateral face, and enophthalmos, apparent recession of the eyeball, enophthalmos. So we have ptosis, meiosis, anhidrosis, and enophthalmos. These are classically seen in Horner syndrome, and Horner syndrome itself has different causes. One of the most common cause of Horner syndrome is what is known as Pancoast tumor or a apical lung tumor, which can cause compression of the sympathetic supply to the eye. It can also be seen, this Horner syndrome can also be seen as a complication of thyroid surgery, in carotid dissection, and even in syringomelia. Then we have a Trotter's triad, which is generally seen in carcinoma of the nasopharynx, specifically of the lateral wall. And here we have three important things. One is the unilateral deafness leading due to ischiochian tube blockage, unilateral palatal palsy. So soft palate immobility would be seen, and ipsilateral trigeminal pain due to involvement of mandibular nerve. Other features of Trotter's triad are, nasopharynx carcinoma are trismus, neck nodes, and sometimes epistaxis can also be seen. So we have epistaxis, positive neck lymph nodes, trismus, unilateral deafness, very important, unilateral palatal palsy, and ipsilateral trigeminal pain due to involvement of mandibular nerve. These are classical triad seen in nasopharyngeal carcinoma, and this is known as Trotter's triad. Then we have Whipple's triad and Conn syndrome. What is Whipple's triad? Commonly seen in insulinoma. Insulinoma, so number one is hypoglycemic symptoms during fasting or exercise. Patient may have tremors, patient may have increased sweating and confusion. If you check the patient's blood glucose, it would have a low blood glucose of less than 40 milligram per deciliter or 2.2 millimoles per liter during the occurrence of these symptoms. And most of these symptoms would be relieved by giving glucose. So symptoms resolved after IV glucose or even feeding also. So these the insulinoma the localization can be done with endoscopic ultrasound, CT or MRI scan, and treatment generally is enucleation if the size is less than 2 centimeter, and diazoxide can be given for medical management. So this is a Whipple's triad classically seen in insulinoma. Then we have Conn syndrome, also seen in primary hyperaldosteronism. So the number one is hypertension without edema, hypokalemia leading to muscle weakness, polyuria and arrhythmias, and alkalosis, metabolic alkalosis because of potassium loss, which shifts the H plus ions intracellularly. So this is a Conn syndrome seen in primary hyperaldosteronism, hypertension, hypokalemia, and alkalosis. Causes generally is adrenal adenoma, one of the most common. And treatment generally is adrenalectomy and spironolactone patient may require. So this is Conn syndrome of primary hyperaldosteronism. Now, 5 P's of acute limb ischemia and compartment syndrome, another very classical, you can say, a constellation of symptoms and signs. The 5 P's of acute limb ischemia, that is pain, which is sudden and severe, pallor with white and mottled extremities, pulselessness, absent distant pulses, paresthesia, patient may have pins and needles and tingling sensation in the lower limbs, and paralysis, which is a very late sign. And these together classically describe acute ischemia. Compartment syndrome. In compartment syndrome, you can add another sixth P, specifically seen in a condition of in the setting of acute limb ischemia. Compartment syndrome can develop, and then you can add a sixth P, that is pain on passive stretch, which is the earliest and the most reliable sign of compartment syndrome in the setting of acute limb ischemia. Pain on passive stretching of the limb is classically seen in an early onset, early sign of compartment syndrome. When the compartment pressure is more than 30 millimeter of mercury or within 30 millimeter mercury of diastolic BP, then the compartment syndrome can develop. Treatment is fasciotomy, or immediate fasciotomy of the leg should be done, and patient, if done immediately, you can save the patient's further complications. So these are the classical 5 P's of acute limb ischemia, and to add on top of that is a sixth P of compartment syndrome. Then we have Courvoisier's law, which is very classically seen in obstructive jaundice. It is a negative statement, remember, and it was described by Ludwig Courvoisier in 1890. And the classical Courvoisier law states that in a jaundiced patient, a palpable gallbladder is unlikely to be due to gallstones. This is a classical statement, it's a negative statement, and that is how it should be told, a Courvoisier's law. In a jaundiced patient, a palpable gallbladder is unlikely to be due to gallstones. Why it is so? Because if the patient has got gallstones, then patient may have chronic cholecystitis, which is one of the common sequelae of long-standing gallstones, and then chronic cholecystitis would cause a fibrosed, shrunken, non-distensible gallbladder that cannot dilate. And that's why if you have a patient of jaundice and also a palpable gallbladder, very unlikely that it's because of cholelithiasis. Palpable gallbladder in a jaundice is most commonly due to carcinoma, head of pancreas, or other periampullary carcinomas like carcinoma of the duodenum, or ampullary carcinoma, or carcinoma of the terminal common bile duct. It can also be seen in CBD stricture or cholangiocarcinoma as discussed. So when you have a patient of jaundice and the gallbladder is palpable, think of malignant cause of obstructive jaundice as the important underlying etiological agent. Of course, there are exceptions to this Courvoisier's law, or pitfalls to this Courvoisier's law. Number one is double impaction. That means one stone is in the common bile duct, one is in the cystic duct. Then also that is an exception. In such a case, even though the stones are present, but the gallbladder will still be palpable because of mucocele. Similarly, mucocele of gallbladder in a long-standing stone, especially impacting in the infundibulum, can also be seen in a patient of obstructive jaundice, even though the etiology is benign. And of course, primary sclerosing cholangitis is another exception to Courvoisier's law. So these are the three classical exceptions: mucocele of gallbladder, double impaction by the stone, and primary sclerosing cholangitis. Then we have Halstead's principles and classic bruising signs. What are the Halstead's principle of surgery? Number one, gentle tissue handling. Needless to say, this is one of the most important principles of surgery: gentle tissue handling. If you respect tissue, the tissues would respect you. The second one is a meticulous hemostasis. That is one of the important core principles of a safe surgery, a meticulous hemostasis. Sharp anatomical dissection rather than a blunt, rough dissection. Sharp anatomical dissection following the anatomical planes would always lead to lesser post-op complications as compared to a going out of the anatomical planes and doing blunt dissection. Tension-free anastomosis, very important, or any closure, because any sutures under tension would lead to further complications post-operatively like surgical site infection or wound dehiscence. Always obliterate any dead space. Don't leave the dead space because it can quickly fill up with serous fluid, leading to seroma or a hematoma and compounding further the post-op complications like surgical site infections. Adequate blood supply should be available to the tissue edges, and that would means that the suture line or the tissue would heal faster. Okay, so these are the 6 principles which are classically the Halstead's principles of surgery, which should be followed by every surgeon for a better outcome. Then we have battle sign, which is location of over the mastoid process. It's basically a mastoid bruising or a mastoid ecchymosis. An important cause of this battle sign is a fracture of the base of the skull fracture, specifically the petrous temporal bone. And patient may also have CSF otoria. That means there may be a passage of CSF through the ears, and patient may also have hemotympanum. So this is a battle sign classically seen in fracture of the base of the skull. And of course, we have Gray Turner sign, which is ecchymotic lesions seen in the flanks or in the lumbar region, classically seen in retroperitoneal hemorrhage of any cause. And Cullen sign is a periumbilical ecchymosis, which can also be seen in a retroperitoneal hemorrhage. Then we have Mirizzi syndrome. Mirizzi syndrome is a stone which is seen in a Hartmann's pouch. Hartmann's pouch. And what exactly is the Hartmann's pouch? It is an infundibulum of the gallbladder, basically the junction of the body and the cystic duct, which is one of the commonest site of stone impaction. And this stone in the Hartmann's pouch at the junction of the body and the cystic duct can compress the common hepatic duct externally, leading to obstructive jaundice. And this is a Mirizzi syndrome. And there are different types of Mirizzi syndrome, which we will discuss subsequently in a different video presentation. But type 1 has got extrinsic compression only, and type 2 to 4 of Mirizzi syndrome also has associated fistula formation. And how do the patient of Mirizzi syndrome present? Basically, they have jaundice because of compression of common hepatic duct externally from the stone impacted in the infundibulum. Jaundice, right hypochondriac pain, and recurrent cholangitis without any CBD stone on ultrasound or CT scan is suggestive of Mirizzi syndrome. So if the patient has jaundice, if the patient has right upper quadrant pain, and also recurrent episodes of cholangitis, but when you do a CT scan or an ultrasound, which may be difficult to pick up a stone, stones are not visible in the common bile duct, then think of Mirizzi syndrome. Investigation to be done are generally a MRCP, magnetic resonance cholangiopancreatography, is a diagnostic investigation for Mirizzi syndrome, and ERCP would be a therapeutic procedure to be done along with stenting. Surgery is high risk because of potential CBD injury, and sometimes you may have to convert it from laparoscopic to open surgery. We have already seen what is Hartmann's pouch. It's an infundibulum of the gallbladder, basically a junction of the gallbladder and the cystic duct, which is one of the commonest site of stone impaction leading to Mirizzi syndrome. What is Callet's triangles? Callet's triangle is a triangle which is seen during cholecystectomy, and what exactly it consists of? A liver edge superiorly, cystic duct, and common hepatic duct medially. So we have a common hepatic duct, which is a medial part. Superiorly, we have a liver, and then we have a cystic duct. This forms a Callet's triangle, which must be dissected in cholecystectomy. And then we have a Hartmann's operation, which is an end sigmoid colostomy, rectal stump closure, generally done in any patients who has got sigmoid perforation or even perforation because of diverticulitis. It's an emergency procedure and a life-saving procedure. End colostomy of sigmoid colon followed by along with a rectal stump closure. Hilton's law. Some laws now in surgery. Hilton's law. A nerve supplying a joint also supplies the muscles, moving it, and the skin over the muscle insertion. For example, a knee joint, femoral, sciatic, and obturator nerve, same nerve supply thigh muscles and skin. What is Bergman's rule or Bergman's law? Fat embolism occurs after fracture of long bones of pelvis. Fat globules enter marrow sinusoids. That is a Bergman's rule. And then we have a Wolff's law. Bone remodels in response to mechanical stresses applied to it. Laplace law is very important law, which is a physics law, but it can be used in surgical practice. Wall tension equals to pressure multiplied by radius. So any thin walled structure would rupture at the widest point. So volvulus would rupture at sigmoid. Aneurysms has a risk of rupture as the diameter increases to more than 5 centimeters, especially aortic aneurysms. So these are the, just to recapitulate, these are the few important things which we discussed. Charcot's triad, pain, fever, jaundice, seen in ascending cholangitis, hypotension, confusion, Reynolds pentad. Virchow's triad, stasis, endothelial injury, and hypocoagulable state in DVT and thrombosis pathogenesis. Beck's triad, low BP, muffled heart sounds, increased JVP, suggestive of cardiac tamponade, do pericardiocentesis. Cushing's triad, hypertension, bradycardia, and irregular breathing, sign of raised intracranial pressure or herniation. Whipple's triad, seen in insulinoma, hypoglycemic symptoms, low blood glucose, and symptoms are relieved with glucose. Courvoisier's law, palpable gallbladder plus jaundice, is not due to stones. It is most likely due to carcinoma head of pancreas, periampullary carcinoma, or cholangiocarcinoma. Horner syndrome, ptosis, meiosis, anhidrosis, and enophthalmos, sympathetic chain disruption due to carotid artery aneurysms, Pancoast tumor. Hilton's law, nerve to joint, same nerve to muscle also moving it, and overlying skin. 5 P's of acute limb ischemia, pain, pallor, pulselessness, paresthesia, and paralysis. Add a sixth one, passive stretch. Passive stretch would lead to increased pain seen in compartment syndrome. And Laplace law, tension is equal to pressure into radius. And so the most of the hollow organs, when the tension rises, would rupture at the widest point. Aneurysmal rupture risk, volvulus rupture. Biggest aneurysm would rupture first as the size increases. So these are the high important ones which we have just discussed, the important triads and the laws. I hope this video would be useful to you. If you have liked my video, please subscribe to my channel, share it with your colleagues and friends, and thank you for watching.